Welcome, everybody. Today's prep webinar is Trauma-Centered Care and Sensory Modulation with Sandy Everett from Klein Forensic Center. I'm going to introduce Sandy in a minute. For those of you that don't know me, I'm Jen Sperduto, and I'm joined by my colleague, Dawn Reinhardt-Wood, and we are from the SPRE team, the State Hospital. Why do I get this wrong every month? The State Hospital Psychiatric Rehabilitation Initiative from Rutgers University Department of Psychiatric Rehabilitation and Counseling Professions. So as you know, this is an interactive training. We encourage you to ask questions throughout. Dawn's going to be manning the chat box. Feel free to type a question or discussion in the chat. Dawn, make sure that we're on everybody. And you might want to change it at the bottom. It says to all attendees or to just panelists and attendees. So if you want everyone to see your question or response, just change that at the bottom of your chat box. A recording of this webinar will be available tomorrow on the Rutgers website. Dawn's going to post a link to that in the chat box. And also, at the end of the presentation today, there'll be a training evaluation link. And from that training evaluation, you can receive a certificate of completion that you attended today, and also links to any resources and handouts that from the presentation today. And our disclaimer is that the PrEP webinars is an online forum for a variety of topics that are relevant to the state psychiatric hospital staff. And while Rutgers and the Division of Behavioral Health Services are co-sponsors of the program, the PrEP webinars are peer presented. And as such, the content is independently developed by the presenter each month. And the views and opinions expressed in the program are those of the speakers and don't necessarily reflect the views or positions of any entities they represent. So just so you know, this is being recorded so that we can post a recording of the webinar tomorrow. And so I'd like to introduce you today to our presenter, Sandy Everett. Sandy has been an occupational therapist for 9 years in a variety of clinical settings, neurotraumatic brain injury settings, and mental health. For nearly 6 years, Sandy has been a full-time principal OT at Klein Forensic Center, providing holistic interventions for patients with severe mental illness. Sandy developed the first mobile sensory program, the COW, or Comfort on Wheels, and she's going to talk about that today, to provide sensory interventions to patients in a maximum security forensic setting. This program improved patients' perception of pain and stress and reduced amounts of seclusion and restraints on a unit with high violent incidents. In addition to having specialized training in sensory modulation, trauma and attachment theory, Sandy has post-professional certification as a culinary nutrition expert, which enables her to educate and coach individuals in epigenetics and therapeutic food preparation for illness prevention. And that was a lot. So Sandy, I'm going to turn this over to you. We're so happy to have you here today, and take it away.
Thank you. Thank you, Jennifer and Dawn, for putting this together. And now that you guys know a little bit about me, I would like to know about the audience. And I have a poll question. So just to get right into it, why did y'all choose to come to this presentation? Now, there's no right or wrong. I would like to just see what everybody else is here for. I think you're just clicking the answer. It's a multiple choice.
Okay, we have about 90% of the results in, so I'll share that with everybody.
Can't wait. Okay. Oh, nobody likes stress balls. Okay. Some people are here to know more about sensory interventions and trauma. One person is a skeptic. Okay. And some people already use this as a sensory approach and treatment. Probably some of my colleagues. Hello, Klein, OTs. All right. All right, next slide. All right, so maybe you're also here because you also heard about the statewide trauma-centered care initiative, which is a movement towards trauma-centered care and involving sensory modulation as an approach, alternative approach to restraint and seclusion, and to reduce violence in our state psychiatric systems. So a couple of years ago, the Division of Behavioral Health Services reached out to occupational therapists throughout the state of New Jersey, working in a variety of hospitals. And we have actually been collaborating very regularly for over a year in developing, and actually we have developed a comprehensive new employee orientation training so that we can change and form the culture here of trauma-centered care by using sensory modulation. So that is one initiative. And you might also be here because you believe that your patients or your consumers within the hospital system have unmet sensory needs and emotional needs that lead to maladaptive functioning in their daily living. So welcome, if that's you. So next slide. At the end of this training, you're going to be able to define sensory modulation. We'll go a little bit more in depth about what it is. You'll gain an understanding of how a complex history of trauma affects sensory modulation. And you will also have a basic toolbox for how to identify and deal with some common sensory processing issues. And we'll differentiate between modulation and processing. A lot of complicated words, but hopefully we'll simplify it here. Next. So to get right into it, sensory modulation is basically how we manage how much input we are to tune into. So right now, some of y'all are choosing to tune into my voice. How much of it, the volume, that's your choice. Some of you might need it cranked up depending on my frequency and how loud my voice is. Some of y'all need to put it really low, and that is perfectly fine for your auditory perception or your hearing. And this helps us to keep calm or to stay alert. So everybody is different. Some people will need to modulate or regulate sensory input to make a lot of it or to reduce it. Or some people just will avoid it altogether. So if you just walk away, you turn your computer off, then maybe either you just find it boring or you're just sensory avoiding altogether, and Zoom trainings might not be your thing. So that's okay. But understanding sensory modulation helps us to learn how patients manage their emotions and their behaviors. And it's really also the ability of a person to become self-aware and to socialize with others while maintaining safe behaviors. For example, I have a patient that I work with daily who stands so close to me and just yells at me. He doesn't have any hearing issues, but he just like yells when he talks, not in an angry way, but just, I think what's happening is that he's not aware of his own internal workings, and his own perception is off. So he needs more of his own input and sound to be able to hear himself talk. So this is an example of how self-awareness, standing too close or so far away from other people, if you approach someone because you want to lean into them to hear what they're saying, but they move away from you, that is a sensory modulation element of how to regulate your own distance around people in a crowd. And also sensory modulation, it allows people to attend to relevant stimuli. So if you're holding a conversation in a crowded setting, or like in a restaurant, for example, how are you focusing on this specific conversation and not all the chatter that's happening all around you? So there's a lot of awareness, but a lot of automatic things that also happen that the nervous system can automatically do for you in an efficient way. Next. And this affects all of us. We are all sensory beings. We experience the world through our senses. So if you think that this might not apply to your patients, you might want to think again, because the truth is the experience of being human is embedded in the sensory events of our daily lives. For example, have you ever worn a soft shirt or sweater? Maybe you're wearing one right now, but all you can feel is that annoying tag in the back. So maybe in the chat you say yes, or you're the person who can wear wool or some kind of like really scratchy clothing and you love it. That's all your wardrobe. And you wonder how someone can wear that all the time. For some people, touching a cactus might feel very therapeutic, whereas others, they'll just scream from it. So it's very interesting because when we see it in our clinical settings, we see patients who might gravitate towards sensations and movements and sounds that just might seem odd, or they might engage in some behaviors that might seem odd or maladaptive, which is basically a big word for doesn't really suit them well in a social environment. For example, I have a patient who every day he's very slow at auditory processing or hearing what the words or even saying his name many times. It's almost like he's ignoring, and that behavior could seem very disrespectful or mean or just dismissive. But the patient is actually not ignoring. He's just very low registration when it comes to sound, and he needs movement. So I tend to just like dance with him and move and get in front of him and do a lot of visual to increase the input, the sensory input, and he'll respond in a conversation. So that's an example, again, of how sensory input and understanding how much and where your patient falls under is very important. And next. And now I just want to poll everybody and ask you, how often do you see those sensory driven behaviors in your setting? So this is a poll again. Very often or sometimes, or do you rarely see it? And you can also respond in the chat. Some people say every day. And if it's every day, how often? Do you see it very often within a day? Okay, all the time. And some people, you might say, I don't know what it looks like. What is sensory? A lot of times there are misconceptions about what sensory patients look like. And I really hate, the saying sensory patient, because we are all sensory people. We're sensory beings. Anna's saying all the time. Hi, Anna. All right, so let's see what the poll looks like. So 57% say very often, 30% say sometimes, 4% say rarely, and I'm curious as to why, and 9% say I don't know what it looks like, and that's fair. Okay. So actually, these are things that you should be a little bit more alerted to, in that we are all sensory beings. We can go to the next slide. And now I'm going to ask you another reflective question, which is, what activities do you do throughout the day when you need to calm down or to de-stress? Or if you're generally a very calm and not very stressed out or high-strung person, what do you do to stay alert and engaged? You can answer in the chat. And while you're answering in the chat and see some of the answers pop up. So some people like to just be silent. Okay. Watch something funny at lunch, movement, exercise. Shake my, okay, some people like to move around, talk to a colleague, drink coffee to stay alert, seek movement, look through the phone. Okay, so we'll keep going through the slides. So some people like to create a lot of noise, or they seek noise. Some people exercise, move a lot. You can cook or control the types of aromas that are in your kitchen, in your home, even in your office. I know some people have diffusers for aromatherapy. Drink coffee, that's a huge sensory component. Control the television. You have scented lotions and sprays. Control the lighting. Some people are vampires like myself. They like it dim lighting unless it's natural lighting like sunlight. Sit by the fireplace. You have a swinging chair. These are awesome. If you like vestibular input, light a candle, listen to music, just sit on your comfy chair with a blanket, plants, and again, oh, your clothing choices. So some people like to have very colorful clothing, and that is very comforting for their senses, or it's alerting. It depends on what you're going for. Taking a hot shower, getting a massage, or giving yourself a massage. So these are all a lot of different things that we do within a given day or segment of the day, and we have choice and an autonomy to engage in these sensory inputs to help us either upregulate, like get more alert and active, or to downregulate, to feel calm and peaceful for the day. And the reason why I bring this up is because a lot of our patients in our settings, they have very limited control. So next slide. Not only do they have developmental and intellectual disabilities, some of them, they have possibly autism spectrum disorders. I know I work on a unit that has a handful of those issues. Patients with sensory processing disorders in and of itself as a category, because you can have sensory processing disorder, like a real clinical disorder. And you can have, in addition to that, significant trauma history, including childhood trauma and psychosis, which is another level of complications. And in some cases, which we have seen, you can have all of the above. But not only that, we have the environmental factors, which is loud, echoey units or wards. The doors are slamming shut, open and shut constantly. The cold wall colors, including the cold walls themselves, made from cement. Think about the walls in your home. When you go home, touch your walls and just see the type of paint, the texture of them. Most of the time it's eggshell, it's smooth. The walls here are very cement. They are textured, they're hard. Limited clothing options for the patients. Usually it's like green and all shades of green, maybe gray. So that is a huge sensory component, how we express them ourselves and how we are visually stimulated. Affects our mood and affects our behaviors. Fluorescent lighting or lack of windows altogether. In fact, there was a prison green spaces study, and they saw that when you add green spaces in prison wards, that it decreases self-harm and violence significantly, just by promoting more sensory input that is greenery and nature themed. Strangers all around. So some of these patients, they don't know who's around them. So that is a sensory overload. Different odors that you're not used to. Imagine your whole life, you're used to a certain smell, and you're exposed to other people with their own odors and the food and things that you have little control over, and also limited therapeutic space altogether. So these are some of the barriers to a healthy sensory environment that a person can control. Next slide. So in order to address that, actually my colleague here, Carol Pletnick, who's an art therapist, and we have developed a Comfort on Wheels program, which is hence the cow spots. It's a mobile sensory program that addressed violence, seclusion, and restraint reduction on a female unit a few years ago. And this was to address the issue of limited space. So we used some of the most popular sensory items after assessing all the patients. and getting to know their sensory profiles, which is a therapeutic, it's an assessment tool that OTs can use to tell if a patient is over responsive, under responsive, and things that we'll get to in a little bit. But we developed this sensory program to address those issues, and actually included some very interesting things that have now become staples in our OT department and our hospital that we use daily with our patients. So next slide will show some of the popular things that the patients like to use. So the vibrating massagers, we have the tattoo art, sound machine or noise machine, weighted scarf, or we use weighted shoulder pads, which I'm currently using to help me stay grounded for the proprioceptive input, Buddha boards, some calm down jars or mindful jars, stress balls. Some people think that sensory is just stress balls, and it's not really true. It's one component of it. Pop rocks is a big one for the gustatory or the taste buds for those who are very oral motor seeking. And also the most popular, the new one that we have right now, is becoming very popular, is the massage chair that gives almost a full body massage and heating and vibration, obviously guided by an OT just to make sure that the sensory input is appropriate. But all those things can fit into a mobile cart, and the sensory experience is brought to the patient since we have very limited space. And we actually did a study or program outcomes to see how effective it was. And next slide. So you'll see in this big chart for a whole year overview, the program, which totaled about 32 patients who participated from beginning to an end. It was a year long, which is quite a bit of time actually. And it was right before the pandemic hit. There were 741 instances or usages of the cow. In 541 of them, which is about 73%, the patients all reported some sort of negative symptom, which is pain or stress. So that's a lot of self-reported stress. And in those 541 instances, next slide, 82% reported a significant decrease or elimination of the symptoms altogether after they used it. And we've been talking about publishing it. We're working through the Department of Health to see how we can appropriately publish the program outcomes, because we did an data analysis. And one of the really interesting things about the research or the program outcomes, rather, it wasn't like a research study, but it was a very good way of telling if the program was effective. Next slide, we found out that the patients overwhelmingly requested or initiated the use of those sensory items than the staff. So it wasn't something that the staff just brought to the patient. So I don't know if you could see, but 396 times the patients requested or initiated use of these items, which is 63%. And what that tells us and why that's so significant is because of the volitional dimension of the sensory approaches. So there's a lot of patient initiation and autonomy. And when they ask for it, they're exerting choice and control, which is a key element to trauma-centered care. Okay, so next slide, and going into trauma-centered care, I just wanted to ask people what y'all think about the percentage of patients in forensic psychiatric settings have experienced trauma. Do you think 100% of them experience trauma, 75%, 50%, or it's just hard to know for sure? So some people are saying, I like the interaction in the chat, 1,000, or maybe that's 10,000. Some people saying 100%. Just be sure to also answer in the poll if you're able to, just to get a good visual for what people think. Do you really think it's 100%? Or is it 75? Not sure. Right. So another good point, if they weren't traumatized before coming into the setting, would you count their admission or their experience of institutionalization to be a trauma in and of itself? So, okay, so 69% said 100 and 31% said 75. Okay, so it's a little bit tricky because, well, in the reference section, I do have a link to, or a citation to a research study that was done by McKenna in the journal, International Journal of Law and Psychiatry, that over the lifetime of patients, mainly males in the forensic psychiatric settings, 100% of them have experienced trauma. However, 75% are attributed to childhood traumas. Okay, so that's still, so somewhere between 75% and 100. Some other research says 98%. So the point is, we can all assume that patients in our settings have experienced some form of trauma or multiple trauma. Okay, so next slide. And the research, they do define what trauma is in their research. That's a valid point. What is not a core focus of trauma-centered care? So this is another poll question. I'm curious to see what you guys think. So not a core focus. Is it to protect the person from any added harm, to prevent re-traumatization, to collaborate with the person and help them develop skills, or to make the environments perfect for healing? So which one of them is not a core focus? All right, let's see what everybody says.
Still coming in.
Still okay, good. People are saying, someone said hi, hello, and someone said life isn't perfect, we have to adapt. Okay. Interesting. I like the type A's that give the answers. They, you know, I'm one of those too. Okay, good. So 83% said to make the environment perfect for healing. That is where I was trying to go. It is, we are trying to protect the people, the consumers or patients from any added harm. We don't want to add to their already complex mental health situation, in addition to the forensic piece and all the other complexities. We're trying to prevent re-traumatization, and our environments in and of themselves can be quite traumatic with all the things that we mentioned. Lack of control in and of itself, lack of physical control of your own environment can be quite traumatic. Not being able to leave or escape. And making it perfect for healing is not realistic. Because life isn't perfect, and we're trying to teach them skills to really adapt and to respond to the environments around them. All right, next one. So we already talked about 100% of patients in the forensic psych hospitals, or somewhere around all of them, have been exposed to trauma. And about 75 of them had exposure to childhood trauma. And many people might know about the ACEs study, and if you don't, maybe look it up later, the Adverse Childhood Experiences study. It makes assumptions about it's actually predictive of later on mental and medical issues in life based on people's exposure to childhood traumas. And why that's relevant to our topic today is because some of top experts now in trauma will talk about the body storing those memories. The body keeps the score, which is a very popular read by Vanderkolk. I highly recommend that. That the stress response is activated by certain triggers in our environments. And we need to basically learn how to cope or to identify those things in our patients. So because sometimes we expect our patients to simply just behave well, be good boys or girls, to stop doing this or that, because when they don't do those things, then obviously they just lack self-control. So that is the logical conclusion, when really they're unable sometimes to regulate themselves and to get rid of unwanted feelings, or to dim down some unwanted feelings or triggers that they have. So how can we blame them if they don't have some of the tools, the therapeutic regulatory tools to help them from feeling those unwanted feelings? Okay, so another thing that we can think of in terms of like the brain is that neurons that fire together, they wire together. So certain experiences have, there's an associative effect. So the sound of the door slamming shut all the time can really over time create this anxiety sensation in patients, where they're constantly, I have a patient who constantly looks around because every time the door slams shut, I don't know exactly what he thinks, he doesn't verbalize, but there's some anxiety provoking experience about the door just slamming shut. Or if someone's just yelling, it might sound like someone, like an abusive parent. It might remind them of an abusive parent who's coming to get them. And that is re-traumatizing in and of itself. The smell of certain colognes or even coffee. Sometimes we tell our, that's why one of the policies here is to not eat or drink in front of patients, because some of them could be really triggered by the smell of someone's coffee breath, if that reminds them of maybe an abuser, maybe an abusive person in their past. So we never know. The sensory environment is very interesting place to just observe. That's number one, is that we can observe. So next slide, we talk about how trauma may appear and what we can observe in patients with trauma histories. We can see all these common things such as depression, hypervigilance, impulsivity. We know those to be some of the common things. But other things that we really observe, especially as OTs in this environment, next slide, are limited to no program attendance, consistent fighting. So maybe a patient who just snaps and in a second will just get into a fight with a peer based on something that they heard. They're easily startled. They're constantly in restraints. They engage in a lot of self-injurious behavior, like scratching their skin or picking at their skin, in foreign body ingestion. So there's difficulties with self-care, not wanting to get into a shower, maybe the water pressure. The sensory aspect of that water pressure is just so awful. The temperature in and of itself, if it's not hot water, you can't even control the temperature of the water here. So those are all sensory barriers to self-care. So we see a lot of these different behaviors, and also there's new research coming out about addictive behaviors through substances, that people want to change their internal state. They want to make whatever sensations or feelings go away. So patients who have a history, so there's a patient on the unit who has a history of going to the hospital because he enjoys getting IV pain meds that makes him feel good. And this patient has been traditionally very resistant to therapy. However, recently he's been initiating a lot of items that we have, such as the vibrating massager and the massage chair. And actually today he leaned back for the first time, just saw his body totally relaxed, closed his eyes. And this is a guy who's very hyper vigilant of his surroundings. He closed his eyes, just leaned back in his chair and enjoyed a massage, and reported a 9 out of 10 in terms of his relaxation sensation today. So that was like, it's interesting because we see the problem patients or the very difficult patients, suddenly in our therapy sessions, they're fine, they're easy, you can engage with them, you can talk to them. And that's one of the beauties of using sensory interventions, is we elicit positive responses through sensory. Next page. So what is the toolbox that we need to get a positive response and have patients to process the environment and process the sensory information? And just to define sensory processing, it's how someone will take information from their senses and make sense of it. But they use prior information, memories, their knowledge, and everything stored in the brain to make a meaningful and functional response. So how do we get them from modulation, which is regulating how much of the input, to processing things? And we facilitate that in our practices. Well, we have to know the patterns. So what patterns do we see in our patients? Next slide. And you guys will have access to this PowerPoint and the handout to review later. So there's 4 main sensory processing patterns. And to determine which one, that's when an occupational therapy assessment or an observation is warranted, because we have the objective measures to do that, the experience of just observing the patient within the environment, and the understanding of how environment and person interact with each other. But anybody can really be able to understand some of these patterns after time and time of observing person. So there's 4 main patterns. Over responsivity or hypersensitivity is one of them. That's when it takes just a small amount of stimuli for a person to feel overwhelmed and to be anxious and impulsive. So this is the person that's usually maybe hands on their ears, like they will immediately respond to just the smallest little sound or even visual. They don't like action movies very much. So you want to think of all the sensory systems, and we'll get into it next slide. Or someone who just the smallest movement, like if their body even moves the smallest bit, they just feel exhausted and depleted and they don't want to do anymore. Under responsivity, on the other hand, it's the opposite. It's also known as low registration. It takes a lot for the person to respond. They may appear avoidant, like the patient I mentioned, who you could say their name, hello, I'm talking to you. They appear bored, or they're easily distracted, and they're not really, they might just seem apathetic to what's happening. And those are the people we might also call isolative. They're just isolated. And now I'd like to point out that you could be isolated, but for totally opposite reasons. That's why it's very important to know, is it because they are hypersensitive and they're avoiding and they just isolate? Or is it because they actually need more sensory input in their environment to get them to respond to a basic question or conversation that's happening? And the other one is sensory seeking. So this is a person who is constantly craving movement and all types of stimuli. They have trouble sitting still. They are taking risks. They're enjoying extreme activities. And sometimes they are those who are engaging in self-injurious behavior. A lot of times you can have a sensory seeker that is also under responsive. So that's when they need a lot of input, a lot of sensory input to make them feel, to take maybe away some of the numbness if they don't feel or respond to cold and hot, or pain perception might actually be very low in terms of intensity. They might need more pain to actually feel pain. You also have people who are sensory avoidant. This is when they tend to actively avoid stimuli. They seem sedentary. They cover their ears during loud noises, dislike change in routine, or seem highly anxious. You might be thinking, well, what's the difference between that and being over responsive? The difference is A sensory avoiding person will actually remove themselves. They are actively avoiding sensation. They are actively doing this, whereas over responsivity, a lot of times the person is not aware. They don't know what they need to do to regulate themselves. They might still be stuck in the situation, but their internal system, their nervous system is all sorts of out of whack, and they are feeling overwhelmed. So they could actually be engaging in self-injurious behavior because they are overwhelmed, but they don't know to avoid sensory input. So there's more on this. Winnie Dunn is the occupational therapist who did tons of research on this, and she published a lot of books. So there's I'm listing her name as a resource if you wanted to read more about this. Next slide, we're going to go into the basic 5 senses. So every sense right here is, you could apply those 4 different patterns to. So someone could be sensory avoidant and visual. They like completely dark room. They don't want any visual stimulation. They could be hypersensitive, over responsive. Same thing with all the 5 senses. But I want to focus on 2 additional ones that we don't really talk about, which is proprioception, and I don't know if you could see the bottom one, it's vestibular. So there are additional 2, and some even say additional 3 senses, which is your proprioception, your vestibular, and one of the newer ones that people are talking about is the interoception, which is sensing what's internally happening in your body, like your digestive system, your internal organs. But we're not going to really talk about that one. I want to talk next about the proprioceptive one, because we see that one a lot. I want everybody to do an exercise of closing your eyes, okay, and put your right arm out straight to the side. So you're going to close your eyes, put your right arm straight to the side. Now close your eyes and make your left arm match your right. Okay. I clearly can't multitask. So you could open your eyes. Proprioception allows you to do that. For some reason, I just couldn't multitask. I don't know if anybody saw me struggle with that, but basically, are you able to match movement, or do you know where your body is in space, even when your sight is occluded? So these are the people that constantly need to look down at their feet when they're walking. Someone that needs to wear layers of clothes, even when the weather is really hot already, like in the summertime. People are calling out other people. Might be those who are roughhousing, constantly just like taking punches at staff, even if it's like in a playful way. Think about toddlers, so they're roughhousing, they're still learning about how their body's moving. But when we talked about trauma stuck you in the past, I don't know if I mentioned that earlier, but patients are stuck in the past in terms of some of their developmental experiences have been just literally stuck at some point. They haven't been able to develop sensory motor wise. So they're still engaging in some seemingly immature behavior. Roughhousing, wearing really tight clothing, layering clothing. You would think that by now, by the age of 18 to 20, people would know how to dress appropriately for weather. That's a life skill we learned by the age of 4 or 5. But some people are literally stuck because their bodies and their developmentally, they never learned that, or they just need that proprioception, their position and awareness of their bodies. They do a lot of leg tapping and shaking while they're sitting down. They're just clumsy or uncoordinated, constantly bumping into things or people. And sometimes we think it's intentional. Like, why is that person constantly bumping into me? And it could be annoying. Some of our officers here, the security staff, can just get annoyed because if you're working 8 to 16-hour shifts with these patients, it's a lot. So some of the interventions that we use it's not just an intervention. It could be assignments or like things that they could do after rehab hours, heavy work. So maybe they could put away their own laundry and push the laundry cart. They could stretch, do some plyometric exercises, some dancing. That kind of movement is really important for them to just make them feel regulated. So going into a little bit of detail, there are people who are so under responsive, which also means that they are input seeking. So going back to the patterns, you can review that later. These are the people that you need just a lot of proprioceptive input for them to really function in their environment. So they might enjoy a deep pressure massage, right? They will walk loudly and just stomp their feet very loudly. And you might think that, okay, this is just such a difficult attention-seeking behavior, but it could actually be they're trying to regulate themselves because they don't know exactly where their body is. They're trying to make themselves feel regulated and safe. This could also be a person who pushes tables, flips tables, bites, kicks, hits, just to feel in control and regulated. So we have a patient who just constantly, it's almost like he doesn't see where you are and he just like walks right into you. And he has a history also of being sexually inappropriate. So sometimes it's hard to tease, is he being overly flirtatious and sexually inappropriate, or is he just trying to get that sensory input of how close is he to other people? And usually we, as an OT, like you learn to give them cues with your arm, maybe stepping away, or just telling them, hey, you're a little bit too close. So cueing, just to make them more aware, because a lot of times they're not aware. And these are also the people that like to hide under blankets or even inside clothing. We'll see a lot of patients cover themselves inside their clothing or going under tables. So that is an example of being under responsive and needing more proprioceptive input to function. Now, the opposite side is you have someone who is overly responsive. So they just want to sit still, don't touch me, don't bother me. They're uncoordinated. They do not like sports or active type of activities. They're very low energy. They might have poor posture, like kind of kyphotic or just like low tone to them. And they might write very lightly. So the pressure on the paper is very light. Unable to climb structures at the playground. This is if you're thinking about children. And they could also be viewed as lazy. So those are some of the common key things that we do see. So the difference between the two is really significant, because depending on what the issue is, then we'll tailor the sensory input. And if we're trying to help patients be successful in the environments, we don't want to bombard the over responsive one with a lot of sensory input. We might, instead of putting them in a massage chair, what the OTs might do is giving them a little massager that is just targeted in one part of their body. So that way their whole body is not vibrating. So they can actually control it too with their own pressure. Or sometimes what we'll do with patients who don't like anybody touching them, or because touch is very important. Touch is an example of other things, like just being able to tolerate your own clothing. So some patients might strip away their clothing. Now that could be out of frustration, but it could also be a sensory issue. But sometimes we'll put just weighted items on them just to tolerate something soft, like neutral warmth, thinking about comfort and also attachment. Maybe some of them just never experienced the neutral warmth, or it's been years and years since they've had you know, a good embrace or hug by somebody. So involving them in a high high activity type of activity, for lack of better words, might be too much. So doing something like a weighted item, weighted blankets is just very grounding, and it's a good step. And then afterwards you can increase more touch, increase movement. So some of the benefits to having an occupational therapy assessment would be to see how we can grade the sensory input to make them more functional and to build a good relationship with the patient as well. And we are, I know, coming short on time. So we're going to go to the next slide, which is vestibular. Again, one of the very important ones, which is our sense of balance and allowing us to walk smoothly and upright. Dysregulation, the way it looks like, is stumbling when you're walking, getting dizzy, falling over easily. Someone can spin around if they're under responsive. They can spin around for long periods of time without getting dizzy or sick. This is the person that is constantly in roller coasters, going from one roller coaster ride to a next without any like vomiting, any reaction whatsoever. Over responsive is someone who just, you can't even barely walk without you know, stumbling and getting dizzy. Interventions is obviously some kind of yoga, changing head positions. And again, we would grade it gradually, use movement. So even in a seated position, just turning your head from side to side, that could be a lot for someone who's just rigid and doesn't like to move. And if they don't move their bodies, they could become stiff and just at risk for pain. And just a lot of other health issues. So it's really important for people to move, and it helps people to regulate and feel relaxed whenever they're feeling agitated. Otherwise, they have no coping skills. A rocking chair is another one, or a Dynadisc, which is a thing like you use them at the gym. I don't have a picture of them, but you could balance yourself and move from side to side. Next slide. So it's important to know that anybody can really help create a positive and therapeutic sensory environment. And it's important to have an occupational therapist assess for the needs, because we could tell specifically what the person might need, might not need, how much of it, how little of it. We could try and recommend different strategies. Develop individualized sensory diets. So that's something that is a little bit more specialized. Creating sensory environments, or if that's not feasible, we can create a mobile sensory cart like the cow, and train staff and patients on safe use of sensory items. So there's a lot of things that we can all do together so that the difficult patient, the ones that might engage in a lot of self-injurious behavior, scratching, picking at their skin, maybe all they need is a lot of like something like this, like a surgical brush with someone teaching them, a therapist teaching them how to elicit a good sensation in their skin so they can regulate themselves. This is an example of something that we do for some of those difficult patients. So now I'd like to thank everybody for attending, and especially our Klein OT department, who are very supportive, and we all are very creative. We're always talking positively about different approaches to work with on the patient, which is important, to not label a patient as a difficult one or as a manipulative person, but maybe they have sensory and emotional needs that are not met by the environment. And there's something that we can do, thinking outside the box, to help them function and be better equipped to handle the chaos that's happening. So I'd like to thank our OT department and my supervisor, Richard, for always supporting. And I'll take all your questions if possible.
So we'd like to open it up for discussion. Feel free to, if you have any questions for Sandy, you could put them in the chat box, or if you would rather speak, you could just raise your hand and Dawn can see that and she can unmute your microphone so you can speak.
So we do have a question from Mr. Bartholomew. I'm sorry, Dr. Bartholomew. And he asked, instead of self-report, could you measure biological variables such as blood pressure, galvanic skin response, etc.?
Yeah, definitely. That's you can measure all those factors, heart rate. Yeah. So self-report in and of itself is not sufficient. You can have more objective measures. I've never measured with galvanic skin responses, so I would actually like to hear if someone else has, if in the chat, just because the limitations of the environment and also limited one-on-one time with patients in a safe space to measure people's blood pressures and do all those things. So I'm curious to see if someone has used it in the past.
And Allie has a really good question. They say, I work in a hospital without very many OTs available. What can a non-OT do to support patients when it comes to sensory needs?
Very good question. Hi, Allie. Definitely observe, get to know the patients, get to know their likes and dislikes, get to see them, observe their patterns of how they interact in their environment. I'm not asking you to do OT and do a full observational assessment, but to just get to know, do they generally like to be aloof and alone whenever music turns on or whenever a lot of people are talking, and then they brighten up when things are a little bit more controlled and quiet. And based on that, just designing the environment a little bit more thoughtfully, so we can be thoughtful about how we run our groups or how we design the environments. Maybe leaving a room at the end of a session for more of the chaotic type of feel, whereas the beginning and middle of a group setting could be a little bit more controlled and predictable for some of those patients who are overwhelmed by sensory input, and vice versa. If patients are just so low arousal, low energy, is there something you could provide for them to keep them alert and active? For example, sitting on like a cushion that has some vibrating input. And now I don't know what the restrictions are in other hospitals, but I do know that in some of the other hospitals like Ancora and Greystone, there are OTs and there's sensory items. So I would assume that that would be easier. In terms of other places where there is no OT, maybe looking into some kind of fidget item to engage those patients that are hard to keep aroused within the confines of security and whatnot. I mean, we are in the maximum security setting, so I think that if we can use some of these items safely, and we have never had any incidents or problems with them. In fact, it's really amazing how we see the difficult patients are somehow just brightening up and they are no longer difficult in our sessions. And we'd like to see that across the board on the units after hours. So just getting to know the patients. Thank you. That's a good question. You don't have to be an OT to make it a sensory inviting atmosphere where they can just either escape, finding an escape route if it's too much, or inviting them to do more through other items like fidget items. Vibrating massagers are really good. So create your own toolbox. I recommend that everybody creates their own toolbox for their client or patient.
And one last question before we wrap up. Dr. Bartholomew says, are there other interventions that are good pairs for SM? I'm not sure what that question is, Tom.
I saw Paris.
I saw Paris too, but I'm thinking he didn't mean Paris.
Oh, pairs.
Pairs for sensory modulation. Pairs?
I would like to, they go to, okay. So
Pairs.
Are you able to unmute, or people are able to talk?
If they raise their hand, they can.
Oh, they can't. Oh, okay. Because I would like to know a little bit more about the question.
All right. So Dawn,
are there interventions that go well? Let me see if I can.
All right. Dawn's going to unmute Tom.
Hi. Yes, this is Tom. You had mentioned like mindfulness, the idea of pairing a sensory intervention with helping the person become more and more aware of their internal state.
Yeah, definitely you can use mindfulness and guided visual imagery for sure. Is that what you're kind of referring to, like those kinds of techniques going with sensory motor?
Yeah, I'm struck. I've been doing this work for so long that we often learn about strategies, but they're in isolation, right? And there's so many good ideas out there. Are there ones that go naturally together?
Yeah, it definitely. So one thing I like about the sensory approach is that it's not just one. You're not doing it in isolation. You can do it in a talk-based therapy session, or like in a grief and loss group that you're, I run with the chaplain here at Klein. We incorporate a lot of sensory experiences, like using lotions, like an ocean themed lotion to think about the beach. Or another peaceful place. So doing guided visual imagery and mindfulness. So there's a lot of creative things that you can do to help the patients learn about their sensory world and how they could control it with their minds, actually. So I hope that answers your question.
Yep.
Okay. And Melissa has her hand up. And then this is the last question because we have to wrap up. Dawn's posting the training evaluation link in the chat, and we will send that out tomorrow. So you have access to all of the resources and handouts, but I'm going to turn it over to Melissa to ask her last question.
Hi, Sandy. It's Melissa from Greystone. How are you?
Hi, Melissa. I'm good.
I wanted to add something to that last question because we have found that sensory pairs really nicely with ACT, the acceptance and commitment therapy. I think that's the right acronym. As well as pairing it with like interoception. So like understanding like our body states as they are, like what our stomach feels like, what our heart feels like, things like that. And that pairs really nicely with sensory, to use like those sensory interventions depending on how our body state feels. So that's all. Just wanted to.
For sure. Thank you so
there.
much. Yeah, thank you. And a separate talk on interoception is definitely needed, because that is one of the most important senses that is not talked about. And I have not used ACT or ACT before, so I'm curious to learn more about that.
We can talk.
Yeah, thanks for coming. Thank you for supporting. Yeah,
of course.
A link to the TED Talk video on the importance of sensory modulation. That link is in the training evaluation, so be sure to go there, fill out the training eval, get your certificate, and the handouts with all the information. Sandy's contact information is also there. And we just want to thank everybody for coming. I know this is a busy holiday week, and so to show up and be here today was great. And Sandy, thank you. This was fascinating. And I wish everyone the happiest of holidays, and we'll see you all at the prep webinar in January. Take care, everybody.
Thank you, everyone.